So thank you for joining us today. My name is Sarah Fordyce and I'm currently Acting State Manager with National Disability Services in Victoria. And I'd like to welcome everyone joining us this morning. And this is the 5th webinar in this series. I'd like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. I pay my respects to their leaders past, present and emerging. I think many of us are getting used to Zoom sessions now, but I'll just run through the practicalities. So can I remind you to please use the question and answer feature located on the navigation bar at the bottom of your screen to ask questions or to make comments throughout. And we'll have some time on our agenda to respond to some of those questions. We'll be posting the slides and a captioned recording of the webinar on our website within a few days. And if you're having any technical difficulties, please use the chat function on the navigation bar and our support team will attempt to assist you. So reflecting that yesterday was Are You OK Day, I'd like to begin today by acknowledging the resilience of so many of you in our sector. It's a really hard slog coping with this virus and keeping up all the additional efforts as the weeks go by, as we live and work under stage 3 and stage 4 restrictions. It's heartening to see these daily numbers of positive cases slowly and rather stubbornly come down. And this is thankfully being reflected in the incidents in disability services as well. So let's keep working together, supporting each other, sharing good practice, and please keep an eye out on those around you, not just on Are You OK Day, but in these days and weeks ahead. So today we've got another full agenda. We're again going to be hearing from James McIsaac from the department, Professor John Catford with his public health update, and Stephen Broadfoot from the NDIA. And we also have Rachel McConville, who's going to talk about waste management in disability services. So it's really an emerging issue. And Rachel's from the Health and Human Services Building Authority. And then our provider perspective today is coming from Natasha Williams from GenU. Whilst it is a full agenda, we're hoping we're going to also have some time to respond to your questions. And then at the end of the webinar, we'll be asking you to respond to our very short evaluation poll. I'd now like to introduce James McIsaac, Executive Director Disability from the Department of Health and Human Services. Thank you, James.
Thank you, Sarah, and hello everyone. Glad to be back here again at this webinar. Can I first just begin by acknowledging the traditional owners of the lands that we're all meeting on this morning and pay my respects to elders past and present. So I think, as Sarah quite rightly points out, this is a tough slog, a hard slog, but we are seeing the light at the end of the tunnel. We are, of course, as Sarah mentioned, seeing the case numbers come down, and I think in terms of case numbers at a metro level, we're seeing the average 14-day figure come down to around about 74 over the last fortnight, and then in regional Victoria, down to 5 new cases per day. So, you know, very positive developments, which again now underpins the next phase of effort, which we're all embarking on around moving to follow on from the roadmap that was announced by the Premier last Sunday, as we now move to work through how do we step through a number of different stages of looking at moving through the different levels to a COVID normal environment later in the month. So I just wanted today to reflect a little bit about the thinking of the department and the work that we are doing around how we'll move through that in the community services, but particularly the disability sector. And focus on some of those changes, noting, of course, that there's still a fair bit of work to be done around revising some of the work and advice that we'll be doing to update public health guidance and advice for the disability sector. And we'll be doing that as we are across a range of different industry settings, and conversations have been occurring over the last week since the Premier made his announcement, and prior to that as well, around how we can clarify information to the sector as we move through these changes. Just might move to the next slide. So I guess the key priorities for the department in the disability area continue around a number of things that I've highlighted earlier. We're continuing to work through support and outbreak management responses through the Victorian Disability Response Centre. We are seeing the numbers come down, and I'll touch on those in a minute, which is very positive. So we are seeing a number of cases clear through the outbreak management team responses and the work we're doing around incident management support for individual outbreaks, mainly, of course, at a residential service level. We are seeing continuing challenges with workforce, and I'll talk a little bit more about some of the measures that we've got in place there. Again, a lot of emphasis around the work we need to do to prevent and prepare for outbreaks now as we see the numbers come down in disability settings. We are learning a lot around the experience of the second wave, and this really means we need to redouble our efforts in terms of prevention, preventing transmission of the virus into disability settings as much as we can, and redoubling our efforts around preparation in terms of preparedness for an outbreak should that occur going forward. And a lot of work occurring as well around the clinical inreach and support from across a number of health services in Victoria that are reaching out, I know, to disability providers to assist around that. And we're looking to coordinate that as much as we can across the state to make sure that we're not tripping over each other as much as we can, with the complexity, of course, of the different relationships across the state. But just turning to the issue of the Premier's announcement and the roadmap that was announced on Sunday, and I'll step through a few slides in a minute. I guess what we're now moving to is understanding, of course, the risk that we've seen in the community, but more specifically in a range of sensitive settings, including disability settings. And we now know, of course, through that experience, that there is significant risk in terms of how the virus has been moving across from households and social gatherings into various workplaces, and then into residential settings. We now know there's significant risk in terms of workforce moving across various work sites, and that's going to be a continuing risk for some time as we move through some of these next steps through the roadmap. We now know that we need good, close, working arrangements, probably more at a granular level with industries about different service settings around how we calibrate our advice and our support, which is sort of underpinning now the work we want to do to get good advice out to the disability sector in terms of advice and the levels of restrictions going forward. Just moving to the next slide, and some of you may have seen this referenced, of course, in the media since the Premier's announcement on Sunday, the modelling that that underpins the thinking behind the roadmap. There is a significant risk of reopening too soon, and the modelling that is up on this slide here shows you the significant risk of moving to reopening too early. If we look to reopen at a 25 average of new cases, and that's a 62% chance. So there's a significant risk there that is underpinning the analysis behind the roadmap and the staged approach, which is aiming to safely and steadily open up across the state. And we'll be doing that, of course, differentially in metropolitan and regional Victoria, but some significant risk there that if we do open too soon, we will lead to what we call the yo-yo effect, and we could well be back into a similar position that we have been recently by Christmas. And if you look at the next slide, this is the modelling that has been undertaken by the University of Melbourne and New England together that underpins the roadmap. you can see there, if on the current trajectory of moving down, if we opened up at 25, we would significantly be exposing ourselves to the risk of having a similar situation by Christmas of a similar level of cases, which would mean that we will be heading back into higher levels of restrictions, which is what we're trying to avoid. So we're trying to avoid that yo-yo effect and to have that safe and steady planned approach. So I might just move to the next slide where we've got a bit of an overview of the step changes across both then metro and rural Victoria or regional Victoria. So this slide goes to some of those changes across metropolitan Melbourne. From the 13th of September, of course, we have a number of changes. The curfew will be extended to 9 p.m. Some opening up of social distancing arrangements in terms of public gatherings, 2 people or a household meeting outdoors for 2 hours is the shift there. We've looked at some of the measures across in New Zealand in terms of the single social bubbles. So we've got an ability now for single households to have 1 nominated visitor, for people living alone to be able to visit a household, and some further then opening up around restrictions in terms of outdoor playgrounds being able to be accessed within 5 kilometres. And then disability services, of course, will still continue to be heavily restricted. And I'll talk a little bit about that in a minute as well. So the issue there is there's a level of restrictions that will apply to the various steps as we move through to a COVID normal environment. And in the metropolitan area, that will be a continuation of currently where we are with the stage 4 level of restriction. So a heavy restricted setting as we move forward with the next step, then the second step from the 28th of September, where we will see the average daily case rate move to 30 to 50 new cases. And that's when we start to see some of these other opening up measures around school starting to open up again for Prep 1 and 2 and Year 11 and 12, and of course also for students in special schools, public gatherings increasing to 5 people from a maximum of 2 households, childcare, early education opening up, outdoor pools opening up. At that point, disability services will still remain heavily restricted, so many of the current settings still remaining in place. Then moving to a third step from the 26th of October, where we move to a setting of the daily case rate between less than 5 new cases, and then to a last step from the 23rd of November, or no new cases for 14 days before then we move to a COVID normal setting once we get to no new cases for 28 days. That's a bit of an overview of the steps. We might move to the next slide, which replicates this across regional Victoria. Again, the second step then being from the 13th of September through then to a similar set of steps. With the last step aligning then to metropolitan Melbourne once we get to no new cases for 28 days and no new active cases in Victoria and no outbreaks of concern. So that's sort of a brief overview of the steps. We will be looking to provide more guidance around the level of restrictions across the various steps for both regional Victoria. We'll look to settle those materials over the course of this week into next week and get that out to you all through the normal channels. We might just move to the next slide. Just a few reminders. Again, the Work and Mobility Reduction Payment Initiative that was announced by the Premier several weeks ago, we have now moved with the NDIA to initiate those payment arrangements that have commenced from 1st of September through to the 31st of December. So those arrangements are now in place, with providers having been written to both by Victoria and the Commonwealth for the respective providers that we are both separately funding. There's a set of core principles that are guiding those arrangements, and we'll have a fact sheet out more generally about this arrangement hopefully later today. Moving on to the next slide. Just quickly, I did mention earlier some of the numbers that have been coming out across the state. Just in the disability area, we've now moved to 30 active cases in disability and community settings, 13 in facility-based settings, and 17 in community. So those numbers are well down now and continue to fall as we clear sites and active cases across both the facility-based area and community-based areas, with a total of 11 facilities. So we would expect that to continue to come down over coming weeks. But again, we are focusing very much now around what we've learned from some of these outbreaks, particularly as we look to strengthen the prevention and preparedness activity across the state. Just moving to the next slide. Just some key reminders here. Again, just making sure everyone's aware that we have the Rapid Response Group website, web address there to provide notifications through to the department, through to the response centre to provide that support through our incident case management. A number of other resources there that I won't go through in detail. We've got e-learning modules up on our website. We're doing some new modules on the P2 N96 mask, which will be available from Monday. So just wanted to draw that to your attention. And just some reminders as well, continuing that any testing for staff or residents of residential services have a priority system. So please make sure that priority 1 is what's on the label when those tests are undertaken. And again, doing a fair bit of work as well around looking at the experience of the outbreak settings and the outbreak experience in Victoria around isolation. And there's some work that we'll be looking to do further with the Commonwealth around that activity, which we might be able to update you on at a future webinar. And I think then just the final slide there is a list of resources. I won't run through those, but that's in the slide deck that we can send out to you all as well. So just in summary, again, as Sarah mentioned, this is a long journey. There's still a fair bit of work to be done in terms of moving through the stretch ahead in terms of working on getting advice out to you all about some of these restrictions. Very grateful for all your support in terms of the work that you are doing across the state, and more than happy to answer any questions this morning, Sarah, that come back from the group.
Thank you very much, James. Thanks for all that information. I'd now like to introduce Professor John Catford, the Senior Medical Advisor, who's going to provide a public health update. Thank you, John.
Well, good morning, everyone. Thank you very much, Sarah. Delighted to be with you today. I'd also like to acknowledge the traditional owners of the lands that we're all meeting on and pay my respects to leaders past, present, and emerging. Well, we, of course, are facing a much more promising, more optimistic situation than we were last week and the weeks prior. As James has mentioned, we are seeing some very important improvements in the cases occurring across Victoria, metropolitan and rural as well. And just to illustrate this, I'd like to share a screen. So I just need to have that screen cleared. Thank you very much. So let me just show you this picture from the dashboard, which is accessible on the department's website. I think you can see here daily new cases falling very markedly over the last month, and we're down to around 51 in the last 24 hours. They do bounce around a bit, and I know we're all looking at the numbers, so it's important for us to actually try and smooth these, and this is why we take a 14-day rolling average, and as James has mentioned, it's now approaching 70 which is unfortunately still a bit higher than the triggers for moving to the next stage. So we need to keep obviously working very aggressively at reducing these numbers over the next week or so. The active cases, of course, have also fallen as a consequence of the new cases each day falling. And we have around 1,500 active cases across Victoria. And 1,000 of those are from aged care facilities. So you can see that this is a very significant challenge for the community, how we can continue to reduce the numbers in aged care, and also too in healthcare workers, because there are also considerable numbers there. I think there are about 250 active cases at the moment with healthcare workers, and I'll say a little bit more about that in a moment. In terms of the regional situation, again, I think we're familiar with this. Really quite low numbers now in regional Victoria, which is absolutely fantastic. But in the metro areas, we still have the continuing issues in northern and western Melbourne, and also down now in the sort of Dandenong area too. But these numbers are, again, very significantly lower than they were a few weeks ago. So still very encouraging. We have this Meatworks initiated outbreak in Colac. That's why that's featuring so clearly in the in the geographical map. I think we just need to keep on going. The restrictions are easing or likely to ease, particularly as we see reductions in the numbers. But perhaps I could just return to this issue about infections in healthcare workers. And I just want to bring up and remind you about I'm going to show another screen, please, sorry. I'd like to remind you about the importance, obviously, of everyone keeping very safe. And this is why there's been just in the last week further advice on the use of personal protective equipment. This is dated the 4th of September. It's on the website. I just want to highlight this important table. Now, this table is about supporting people who are COVID positive or suspected of being COVID positive or are close contacts of a confirmed case. So we have to consider all these categories potentially infectious, and therefore healthcare workers and support workers in disability need to protect themselves. And there are different levels of PPE according to the situation you're in. So if you're not providing hands-on care, a surgical mask and eye protection is sufficient, although we would prefer people to wear a face shield because it does cover the whole face and there is added protection. If you're providing hands-on care for very short periods, this is 15 minutes or cumulative during a shift, you can continue to wear your surgical mask and eye protection face shield. But if you are providing prolonged care for a client with COVID or suspected or close contact, then you should wear a respirator, a P2N95 mask. And that's what the e-learn is all about, which is going to be published next week. So if you're supporting someone for 15 minutes or more cumulative, so you add up the time during a shift, you should be wearing a P2N95 mask. And there's also a situation that if there was likely to be aerosol generating behaviors for even a short period, you should also wear P2N95 masks. Now, there is further information in this guidance, so I won't go into that in any greater detail. But I just want to highlight, though, that wearing a P2N95 mask is more challenging than wearing a surgical mask. And the reason for that is we really want these masks to fit very well on your face. Now, there are different types of masks and different sizes, and we are encouraging people to do what's called a fit test. You need to have practiced using these masks and work and which mask is the right one for you. That's called a fit test. So you should do this in advance before providing care. And when you do put on the respirator or mask for a period of care, you should also do a fit check. And that's basically to check to make sure that the mask is not leaking and that the air is sort of coming in through the sides or on the top. The eLearn talks about this, and there is information in this fact sheet further on how to do a fit check. I'm very happy to take any questions on that. But let me just say one or two things about these masks. Now, there are all different types and models of P2 N95 mask. P2 is the European standard. It's also the standard that we use in Australia. The N95 is an American standard, and they're both equivalent. So P2 and N95s are exactly the same, and they work the same. That there is also a mask provided which is called a KN95, and it comes out of China. It's a Chinese standard. The filtering is certainly as good, but there have been some concerns about how well these masks fit. And as a result, the Therapeutic Goods Administration is doing a review of this. So our current advice is, in preference, to use P2 N95 masks in preference to the KN95 mask until we get some further advice about the suitability and the appropriateness of those masks. They're certainly better than surgical masks, but the P2 N95s are probably more likely to fit you. There are also some fact sheets that have just been published on the website for disability workers on wearing face masks, and also another one for clients, for people with disability. So I refer you to those as well. So I think that's a very quick run through. Please keep safe. We really need you. We don't want the numbers of healthcare workers, support workers increasing, and we want to keep them coming down. So thank you very much. Thanks, Sarah.
Thank you very much. Appreciate that. We're now moving on, and we have a brief update from Stephen Broadfoot, a branch manager with the National Disability Insurance Agency. Thank you, Stephen.
Good morning, Sarah, and good morning all. Thanks for the opportunity to speak to this group again. Before I begin, I'd like to acknowledge the traditional owners and custodians of the countries on which we virtually meet today, and acknowledge their continuing connection to land, sea and community. I pay my respects to their elders past, present and emerging. In conversation with Sarah and a number of other providers over the last week or two, I understand there's a number of questions in relation to the Victorian Worker Mobility Payment Initiative, how the costs of PPE and other COVID-related supports are put into plans, and also how providers can claim PPE costs. So three reasonably solid topics there. So I thought I'd focus my time on those today. So in relation to the Victorian Worker Mobility Payment Initiative, as mentioned by James of DHHS previously, the Commonwealth and Victorian governments are working together to implement a Victorian Worker Mobility Reduction Payment Initiative to support SIL and STA providers during the COVID pandemic. The initiative will offer support to registered SIL and STA providers in Victoria to support efforts to minimise their staff working across different sites and reduce the risk of cross-site infection. As mentioned by James, the NDA will support and administer the initiative for NDIS registered SIL and STA providers that are fully within the NDIS scheme, and the Victorian Government will support residential service providers that have not yet fully transferred to the NDIS. Those providers that are eligible for the scheme or the initiative can opt in or need to opt in into the initiative, and they can do that by responding to an email that the NDIA sent to eligible providers last Friday, so the 4th of September. One thing I'll just mention is that if you think you're eligible and you haven't received the email as yet, I ask you to please check the email address registered in your NDIS My Place portal profile. We are getting some responses saying agencies or organisations haven't received the email offer, and it's gone to an email address that's not monitored at that point in time. So if I can ask you to just check that it's gone to the right email address. If you think you're eligible, you've checked your email address and you still don't have that email offer, please contact the NDIA via provider.support@ndis.gov.au, and we'll respond to your individual inquiry. Just a general reminder that to accept the initiative or to opt into the initiative, you do need to accept the terms and conditions set out in the email sent to you on the 4th of September, and you need to sign and return a copy of that letter to say that you do wish to opt into the initiative. That response needs to be returned to the NDIA by the end of the month. Providers will be responsible for ensuring payments from the NDIA or via the initiative go towards offsetting costs associated with reducing worker mobility. Importantly, funding will be paid in arrears, and eligible providers can access payments via directly invoicing the NDIA. And providers can invoice us either fortnightly or monthly. We are happy to pay on that regularity that best suits the provider. The other requirement as part of opting into this initiative is that providers do need to demonstrate adherence to public health directions. And to demonstrate that, we're asking providers or eligible providers to provide monthly information to the NDIA on topics such as how many workers do you have that are working across more than one site, and what's been done to minimise worker mobility in your services. What workers have you compensated, i.e. a list of name and amounts, and how many workers you have and how many of these have declared they work in other locations. And I think it's important to note that by and large, the reporting requirements that the NDIA and DHHS have in place are fairly aligned in that space. So hopefully that reduces any overhead or administration issues for providers that may be eligible to receive or opt into the initiative via both DHHS and the NDIA. There's further information available about the initiative on the NDIS website. Moving on to the next topic in relation to additional COVID funding. There's just a general reminder, there's 2 new support items available to assist SIL providers with COVID-related costs. They're deep cleaning services and additional supports. Those 2 support items are available for participants living in SIL arrangements. The deep cleaning cost is an amount of $300. The additional COVID cost is an amount of $1,200. And the questions we've been receiving about those costs is how they put into plans. So I think it's just might be helpful to provide some visibility of that. So some plans, if they're close to being reviewed, so i.e. they're close to their end date, we are advising the provider to draw down from the current budget, and a plan review can be brought forward. This allows timely access and less disruption to the plan in general. We do, if required, we're happy to add funds to plans via light touch review process, but we do try to avoid that because it does have some downstream impacts on service bookings. But as mentioned, very happy to initiate those plan reviews if required. As always, participants should be aware of the funds being claimed, but extra service agreements are not necessarily required. And good record keeping would be expected. So whilst that $1,200 cost can be claimed for whatever costs you deem necessary, you may be asked to acquit those costs or justify those costs in future. So I think we've spoken previously around that $1,200 a day funding can be used for a range of things, whether that's for bringing additional staff, whether it's for bringing additional mobile toilets, etc., etc. It really is up to the discretion of the provider, and the NDIA will not be definitive in relation to what those costs should be. And finally, in relation to claiming PPE costs, PPE costs for self and plan managed participants should continue to be claimed as per normal processes. The PPE costs for agency managed participants can be claimed either via direct invoicing or via normal processes, but not both ways for the same participant. And if you wish to directly invoice the NDIA, you can do this via the NDIA MyPlace portal. The reason why we're limiting this to registered providers is that participant numbers are required to be included on the invoice, and we understand a number of self and plan managed participants aren't always comfortable in providing that information to other providers. So I think I might just pause there. I can see Sarah giving me the hurry up, so I'm going to pause there, and happy to take questions at the end of the day.
Thank you, Steve. And any questions we don't get to today, we'll certainly be responding to and putting them up on our website in coming days. I would now like to welcome Rachel McConville, who's going to provide an update on clinical waste management in our disability settings. So thank you very much, Rachel.
Thanks, Sarah. I'd like to first acknowledge the traditional owners on which we're all meeting today. So clinical waste, if we could move on to the next slide, please. Clinical waste might not be something that people have thought about very much in the past. But it is actually, we've seen it become a huge issue in terms of being able to be collected and its generation, definitely in aged care settings during this wave. What we've seen is that basically there's been some misinformation about what clinical waste is, which means that people have kind of been scared and put everything in a clinical waste bin, which is understandable. But also we believe there's just been a lack of preparation and a lack of recognition that this could actually be a problem, which has meant that collections haven't been organised, bins haven't been organised before there's actually been a problem. So before there's been an outbreak, there hasn't been much organisation. So this is basically to say, please put things in place now so that hopefully you don't, but if you have an outbreak, things are in place already. So first of all, the thing to remember about clinical waste is that the workplace and the staff who generate it are responsible for the storage, handling and disposal of the clinical waste. If it's found out that it's all going to landfill, if it's found out, you might have put it in your yellow bag, but the contractor's then taking it to landfill, that's your responsibility still. So it's really important that you know exactly what's happening to that waste, both within your facility, but also once it's taken away to be handled, to be disposed of, sorry. Some of the main reasons that it's really important to manage this correctly is that it reduces infection risk for staff and patients. Obviously, if you only have people handling this waste a lot, even if it's just the bins, then there's a risk of transfer of infection. There's also EPA and WorkSafe rules around this. If they find that things aren't being managed correctly, there are a number of different fines and things that they can bring down on a facility. It reduces damage to the environment. as well, and it also reduces waste management costs. The costs of a clinical waste bin are huge compared to a general waste bin or a recycling bin. Making sure we get the right things in each bin reduce the costs that are kind of taken on by the facility. So if we go to the next slide, please. So first of all, what is clinical waste if you do not have a client or a patient with COVID-19? So the decision-making process you have this item in your hand, and the first thing you have to ask is, can you see blood or body fluids on the item? If you cannot see blood or body fluids on the item, then you have to ask another question, which is, does the client have an infectious disease? So if there's no blood or body fluids on the item, if there are blood or body fluids on the item, it is clinical waste. If there aren't, then you have to ask whether it comes from a patient with an infectious disease. If it does, again, it is clinical waste. And if the answer to both of those questions is no, then it can go into the general waste or into the recycling bin. So that's blood, body fluids, or infection. They're the three things you need to think about. Now, just to make everything a little bit more complicated, if the body fluid is feces, urine, vomit, or sputum, they're not counted as being clinical waste unless you can see blood in there. So next slide, please. So an example of that would be Jessica needs to dispose of a used continence aid and it doesn't have blood on it, and the client is not suspected of having an infectious disease. So that item would go into the general waste bin. Whereas if you were disposing of a tissue and it has blood on it, then that does have to go into a clinical waste bin. Next slide, please. So what if you do have a case of COVID-19? What if you do have a patient in your facility who has COVID? So all waste from a patient confirmed or suspected of having COVID-19 must go into a clinical waste bin. Now, where this can get confusing, with where we've seen definitely in aged care, is then the assumption is that absolutely everything in that building is clinical waste, and that's not the case. So if you are making sure or are able to make sure that the person with COVID is in a specific area, is kind of confined to a specific room or a specific space, then the things in that area are clinical waste. But if you have a kitchen and they haven't been into that kitchen, then the stuff in the kitchen isn't clinical waste. So it's the area that has been kind of affected or touched by that patient where you need to be putting things into the clinical waste bin. Next slide, please. So what is a suspected or a confirmed case? So a suspected case is someone who meets the clinical criteria for testing. So that clinical criteria is quite long-winded, but it is available on the DHHS website. But it's things like the respiratory symptoms. In cases of elderly people, there are other symptoms as well. So I definitely would have a look at the website to find out what those clinical testing criteria are. But it's not a case of, oh, maybe we all have it, so we're all suspected of having it, or this facility is in quarantine, so everything in there is clinical waste. That's not the case. That's not what a suspected case is. A suspected case is that clinical criteria, and a confirmed case is obviously someone who's tested positive. So next slide, please. So some examples of that would be, so if you have again a COVID positive person in the facility, so if you're looking after someone who has COVID-19, you need to dispose of all PPE and any other waste items that have been in that patient's room in the clinical waste bin. But as I said already, Dave is in the kitchen preparing food in a facility with COVID-19 patients, but the patients haven't entered the kitchen, and so the waste items in that kitchen can go into the general waste or into the recycling bin. Next slide, please. So some other clinical waste streams that really need to be in place as well, and I don't know if you're familiar with these, but first of all, sharp spins. So a sharp spin is anything able to cut or penetrate the skin, and also pharmaceutical bins. So a pharmaceutical bin is for any pharmaceutical substance or container. Now there's a lot more detail on what that actually means on the DHHS website. But a sharp and a pharmaceutical, they're treated in different ways. So if you have a needle syringe with pharmaceutical in there, it has to go into the pharmaceutical bin so it can be incinerated. If you put that pharmaceutical product into a sharp spin, it won't be treated in a way that kind of neutralizes the pharmaceutical, and that means you're actually then damaging the environment by then sending it along the sharps process of destruction and disposal. Next slide, please. So there are a lot of references available. The EPA, once kind of we realised that there was a problem with all of this, the EPA released information around disposing of clinical waste and disposing of PPE at home and in the workplace. So please go and have a look at those, because there's information in those around setting up a new collection, around how to actually move the bins out to be collected in terms of making sure they're clean and safe for handling. But also the Department of Health released in January, actually, so it's almost like we knew this was coming. We released a lot more detailed guidance around just working out whether something is or isn't clinical waste. There's infection control guidance as well. So I would really recommend that you go and have a look at all of these references and get familiar with them. And that's everything from me. Thank you.
Thank you so much. That's very interesting. And just to flag that NDS will be doing further work and on this clinical waste management issue, both getting out information and working with providers in different settings, seeing how it applies perhaps to the in-home support setting and so forth. So look out for that. We'll be getting some further information out. I would now like to introduce Natasha Williams, who's going to provide our provider perspective. Natasha's from GenU. Thank you, Natasha.
Hi, Sarah. I've only got 10 minutes, so I'll quickly run through this and just hopefully share a few of our learnings from our outbreak that we had recently. So in relation to our workforce preparation, we were having safety conversations with every resident, every worker, every family, and in every house. So those conversations were the what if conversations. So what if someone from your own family has COVID? What if one of the residents is diagnosed with COVID? What if you have to isolate for 4 weeks? How will you come to work? Do you need somewhere to stay? And also with the residents in relation to what if all the workforce couldn't support you anymore? We may have to have someone supporting you who you don't know. And those conversations at the start were one of the best strategies we had, and we realised at the end were some of the best conversations we'd invested in. We had got together a group of COVID casuals, which we call COVID casuals. It's probably not a great name, but that's what we called them. And they were a group of students studying their Cert 3s and Cert 4s in disability. And at the time, we'd brought them into paid shifts during COVID 1 into our sites to help those people become familiar with residents and the houses. And since COVID 2's come in, some of those people have actually continued to study and become full-time workers. We'd minimised our mobility in Melbourne. We'd supplied all our sites with PPE, and we'd even set up a warehouse in Geelong through our AGE area, and that's still running strong. We'd done business continuity planning and lots of training, and we prepared and sent communications to people, but also had prepared some mock communications in relation to the outbreak when and if that was going to happen. We engaged private testing companies for workers, and we also prepared essential info in all houses for new workers that might have to come in who weren't that familiar with the site. Next slide, please. The situations that resulted in us having lockdowns at GenU, we had a worker test positive. We had several occasions where sole providers had notified us that they had tested positive after they'd visited a resident in the last week. We'd had situations where sole providers had been working alongside GenU staff and had tested positive. We had a lockdown after a resident was showing signs of COVID, but was unable to be tested because he didn't want to be tested He probably didn't have the cognitive ability, to be honest, to understand what that meant, but he certainly wasn't letting anybody put that swab in his throat. So what we did is we tested other people around him, but we still locked that house down for 14 days. And obviously we've had lockdowns when residents have been tested. The outbreak, next slide please. The outbreak we had happened on a Friday afternoon, because everything in disability services happens on a Friday afternoon. And that was the advice to us was a worker had tested positive due to an event outside of work. So all the staff were considered close contact, and there was a total of 8 staff that were sent home that afternoon, or sent away and were able to work. Because we had restricted mobility between the 3 houses that were close by in the north of Melbourne that this had happened in, we were able to redeploy other workers. We certainly did need to pay people additional penalties, and we didn't quite have enough PPE on that Friday afternoon. So thanks to our colleagues at Life Without Barriers, we had some masks delivered later in the afternoon from them. We had delivered the communications that we'd pre-prepared to our residents and staff. And I think sometime over that weekend, we had a discussion within our management group and our emergency group around what we should and shouldn't be communicating to our staff and residents. And somewhere on the Sunday, I think we said, you know what, we just need to tell people the truth. If 3 people have COVID, if 1 resident has COVID, whatever it is, we just need to tell people the truth. And I think those transparent communications were some of the best decisions that we had made. We certainly had waste and cleaning in place. And interesting enough, one of our staff who had COVID in the end was a staff member that we had redeployed from the other house after we cleaned the house, after everyone with COVID had gone from the house. That worker tested positive. So we knew then that PPE was an issue for us. We're certainly unable to isolate the 1 resident that became positive, and she shared a house with 2 other people. So there was 3 middle-aged ladies sharing a house with 1 accessible bathroom. And that was a really big problem in relation to isolation. In relation to the learnings, next slide please, we needed to have more PPE in place. We didn't have enough. We thought we did, but we didn't have enough. And we certainly now realise the importance of donning and doffing that PPE. We've since put in place competency assessments, and our practice nurses literally virtually have met one-on-one with each of our workers all across Melbourne, and they've had competency assessments in the last couple of weeks. We've learnt that we need to have staff in reserve, and potentially if that situation on a Friday night had happened in one of our areas where we didn't have the restrictions around mobility in place. So if it had happened in the middle of the Geelong on that Friday night, there potentially would have been 4 houses that were taken out rather than 1 as far as workforce goes. So we've learned a lot about that in relation to having staff in reserve. And in those high complex houses, we've actually got almost a bit of a SWAT team hanging on the side there, a couple of people that we've paid to do some work from home on the condition that they would be there, and they're quite highly skilled and they're some of the most experienced people, and they could go into any situation. We've really learned a lot about virtual supervision options and the importance of using apps such as WhatsApp, and the reality that supervision between a team leader and a worker can happen virtually, and that's probably something we didn't consider in the past. I think capital considerations in the future are going to be a great big learning from COVID, and certainly the lady that had gone to hospital, the Austin Hospital in Melbourne, she was very unhappy about having to leave her own home because she couldn't be isolated. And even though she'd tested positive for COVID, she didn't have any signs and symptoms, and she would have much preferred to stay at home. So I think the way people choose where they live is going to change in the future. Like I said before, the honest and constant safety conversations have been a great initiative for GenU, and I guess what we know now and we didn't know then, we really didn't know that much about people's outside employment, even though we thought we had. Obviously, PPE and the isolation issues are continuing to present an issue for residents. Next slide, last slide. In where we are now, so we've got some exhausted staff. People aren't taking sick leave. There's no weddings, parties or anything to go to. There's nowhere to go, so you might as well go to work. And we expect that will create leave and surge issues later in the year when the restrictions come off and no one wants to be at work because no one's actually had a holiday all year. So we've had to do a lot of leave planning now. We've recruited and screened a whole lot of new workers through our recruitment arm of GenU, and we've trained those people in COVID-related skills. So these are people who are willing and available to work to support people who have a disability, however, haven't necessarily come from a background of disability services. They have got a whole lot of customer service skills, but not necessarily in disability. So at the moment, they're working alongside experienced staff in Melbourne, and they're now this week enrolling in their Certs 3 and 4 on disability. So we've got 40 workforce ready staff in Melbourne that are access to us. So if anyone needs those staff, let us know. But we're certainly expecting that we're going to have some kind of workforce demands later in the year. The last slide is just my name and contact details, and I'm sorry I rushed that. I was just trying to get through my time. There you go, Sarah.
No, thank you very much. Some great insights there. I think people appreciate it. Thank you to all our panelists. Can I ask everyone to respond to our very short survey that we're putting up? Really appreciate that. We're just about at time, but if I could just ask, one of the questions that's been coming up is around worker permits. Can I ask James? We understand that the original permits went through to the 13th of this month, and we've had can they just be rolled over? Is there any advice regarding that? Thank you.
Just unmuting there, Sarah. Yeah, there is advice now up on our DHHS website that they can be rolled over. So happy to get that link out as well, Sarah, through NDS out to everyone.
Great, thank you. And a quick query for John. There's a query about the N95 masks. Are the ones with valves the suitable masks?
Sorry, Sarah, just say again.
Are the N95 masks with valves suitable?
With valves?
Yes.
No, they're not. No. I mean, the reason for this is you want to stop breathing in and breathing out viral particles. So they're not recommended, no.
Thank you. And a query around waste management. Are there any guidelines for handling laundry?
So laundry is a bit of a separate thing, but if you have a laundry service already, then carry on using it. If bedding and everything, as long as it's washed at the correct temperatures, that's fine.
Thank you. So thank you again to our panelists, and thank you to everyone for listening today. And we'll be continuing with these fortnightly webinars over coming weeks. And we'll also keep putting out lots of updates and information. So please keep an eye out on our website, on our coronavirus hub. We've got a Victorian response element part of that. We're also initiating a number of smaller group meetings with a focus on particular settings in disability services. And so that will enable us to work together on particular challenges with infection control and business continuity in different settings. And we continue to be keen to hear your issues and concerns so we can make sure that the voice of disability services is heard in the development of these government and authority responses. So I'd like to close the meeting now and hope you all stay safe. Thank you.